Hello, everybody. Welcome from whichever time zone it is from which you're dialing into this session today. My name's Annabel Crabb, and I'm very pleased to be here with you for the latest breast cancer trials Q&A. Now, you know the format. I'm sure a number of you on this call have been to these sessions before. It involves a person who knows absolutely nothing about breast cancer, i.e. me, asking your questions to a panel of people who know an inordinate amount about breast cancer, either because they have had or have it, or because they've devoted their professional lives to working out how to eliminate it. So it's all happening under the auspices, of course, of Breast Cancer Trials, which is the largest independent oncology research group in Australia and New Zealand. They've been conducting clinical trials, research into the treatment and protection of breast cancer since 1978, and regularly hold these sessions to give you direct access to the experts who are leading the advances in research into this field. In these sessions, we've covered everything from recurrence to the side effects of treatment, to the BRCA gene, to sex life during treatment for breast cancer. Tonight, we're talking about everything we can think of in relation to triple-negative breast cancer. Now, this is a kind of cancer that accounts for 15% of all breast cancers. And as the name suggests, it's triple-negative. It's kind of a triple threat because it doesn't have any of the three receptors that are commonly found on breast cancer cells: estrogen, progesterone, and HER2 receptors. So tonight we're going to be answering as many of your questions, which you've kindly sent in, as possible, and talking about research into this disease. I will have a couple of items of housekeeping before we get underway. First of all, I know you're coming in from many, many time zones and many, many points of the globe, but I would like to, on behalf of all of us, acknowledge the traditional owners of whichever place it is from which you're joining this conversation tonight, and to honour and acknowledge their elders, past, present, and emerging. Now, there is a long tradition on this continent and others of seeking wisdom from the wise, and that is what we are doing this afternoon. We are blessed with the technology of Zoom, which is going to be fine, even though I'm involved in this session, and I tend to have a destructive effect on all technology, but I am surrounded by trained adults, and it is going to work out, I promise. Now, if you have a look at the screen that you're confronting and you go down to the bottom right-hand corner, you'll see three small dots. Hover your mouse over those three dots and you'll see some options. You can make a comment or send a question if you click on Ask a Question. Now, we've got questions coming out of our proverbials. If we don't get to yours, then you will be contacted after the broadcast. You can make a comment or send a question just by clicking on that Ask a Question. One of the other widgets that is a feature of these sessions is that we're going to have a few polls where we ask our live audience about their experiences with triple-negative breast cancer. You'll be able to access that again via those three little dots on your bottom right-hand side and clicking polls. So I think that's more or less covered. I mean, I'm fairly confident. We had one panelist who was going to be in Italy this afternoon, and I was going to be at the Ubud Writers Festival, but then I came home early because I was a bit freaked out by unreliable Wi-Fi. I think we are going to be just fine here, and thank you for your company. I'm going to move on now to introduce our panel. As ever, it's a combination of people with lived experience of breast cancer and people who are at the coalface of treatment and research. So first of all, I'd like to introduce Dr. Diane Barker. Diane was diagnosed with locally advanced triple-negative breast cancer in December 2020. She is not a doctor of medicine, she is a doctor of archaeology, which makes her extremely useful for finding fossils in your backyard, but not very useful for medical emergencies on planes. She's also a lawyer. She's really preposterously overqualified, and we welcome her on this panel this afternoon. We also have Karen Alexander, who was diagnosed with triple-negative breast cancer in 2011, and she has a BRCA gene mutation, which is something I'm sure that is familiar to at least some of you tuning into this call. Karen's also a member of the Consumer Advisory Panel at Breast Cancer Trials, which benefits from a lot of people with lived experience donating and contributing their expertise. Then we have Professor Sunil Lakhani. He's the Executive Director of Research and Senior Staff Specialist at Pathology Queensland. He is coming in from Queensland, so he is enjoying a different time zone from the rest of us, but we will not tease him or other Queenslanders about that. He's the head of the Breast Group Centre for Clinical Research at the University of Queensland in Brisbane. Sunil is also the chair of the Board of Directors at Breast Cancer Trials. Then we have Dr. Stephen Luen, who is a medical oncologist and translational researcher. That's a great title, isn't it? Translational researcher at the Peter MacCallum Cancer Centre in Melbourne. And finally, we have Dr. Jocelyn Lippey, who is a breast surgeon from St Vincent's Hospital in Melbourne. Welcome, everybody, and thank you for making time to have questions fired at you from people who are appearing remotely. Right. This has been a very popular session. There are just nudging 2,000 people who have signed up for this call. So obviously there's a lot of thirst for information, as there is for every area of breast cancer. It is a voyage of discovery on which most people start with zero knowledge whatsoever. So the privilege of being able to hear directly from experts is a great thing indeed. So I'm going to get stuck straight into questions. Welcome to you all. I'm going to get stuck straight into questions because we have a lot of them to get through. The first one, and this is drawn from questions that you've all sent through, is for Diane. Diane, this is not fossil related. It is breast cancer related. You were diagnosed with triple negative breast cancer in 2020. Very nasty year to be diagnosed with anything. Can you tell us how you found out that you had breast cancer?
Sure. Thanks, Annabel, and welcome everyone. I remember in the lead up to my diagnosis in December 2020, I had this incredible fatigue, tireder than I had ever been before in my life, and I couldn't quite figure out why. And I was actually in the process of going down the route of getting a sleep study done because I couldn't figure out why I was getting so tired. It was COVID, there was homeschooling, but I just couldn't work out why I was so tired. But at the same time, I did notice some swelling in my right breast, and I wasn't too worried about it because I had my regular mammogram coming up, and my previous results the year prior were normal. I'd started, getting regular mammograms at the age of 40 because I had a history of breast cancer in my family. My mum had breast cancer, so my GP thought it would be a good idea. The mammogram was delayed slightly because of COVID, but not by too much, maybe a month or two. And then I went, had my routine mammogram, got called back, which is not a position anyone ever wants to be in. Saw the specialist radiologist, who then wanted me to come back for a biopsy. Had the biopsy done, and then a couple of days later got the results from my GP, indicating that it was breast cancer, and it was triple negative breast cancer, which I hadn't actually heard of prior to that. I had no idea about the detailed subtypes. So it was a bit of a shock. Then that started 18 months of quite full-on treatment.
And what treatments were those?
So I had basically just about everything that I could possibly have. So I started off, I got a portacath inserted to make it much easier. And I highly recommend that because I did look with sympathy on other chemotherapy patients where the nurses were trying to access veins, and after a long period of time it can become very difficult. So I had the port inserted, then I had 2 rounds of IV chemotherapy, which were quite rough, I'd have to say. After that I had a bit of a break, and then I had surgery because one of my lymph nodes was looking like it was growing suspiciously. So I had a full mastectomy on the right side, plus an axillary node clearance. I had 10 lymph nodes taken out under my armpit, which was quite a lot. Then had a bit of a break to recover, and then I had 5 weeks of radiotherapy. I managed to get a shocking case of shingles just after I finished because my immune system was so depressed, and I didn't appreciate it was so depressed at the time. So got through that. And then when I recovered from all of that, I had 6 months of oral chemotherapy. But also I had 12 months of immunotherapy. So I was on pembrolizumab for 12 months, which was at that time still not widely available, and I don't think it is widely available for breast cancer patients. And I went through the program with the pharmaceutical company. They have a compassionate program where you pay up front for a certain number of rounds, and then at a certain point in time you are able to access it for free, but it's still prohibitively expensive. I've also had 2 rounds of reconstructive surgery, plus a whole range of allied health treatments, lymphedema, physiotherapy, acupuncture, exercise physiology, counselling, that sort of thing. So, yeah, it's been it's still going. A lot of these things are, I'm still managing cancer treatment. It has a very long tail, but I'm pleased to say that I think I've come out of the other end of it. I'm almost 3 years post-diagnosis, which my specialists are really happy about.
And how are you feeling?
I'm pretty good, actually. I take my health really, really seriously. I took the advice in relation to exercise particularly seriously. So I exercise a lot. I eat well. I still probably don't get enough sleep, but I'm working on that. But I'm feeling positive. That can be a hard thing to maintain, but I'm still trying whatever I can to remain positive. I've got a lot to live for. So it's going well at the moment.
Good on you, Diane. That's great to hear, and thank you for sharing. I'm going to switch now to Karen and ask you, Karen Alexander. You were diagnosed in 2011, so some time ago, and you have the BRCA gene mutation. Can you tell us about your diagnosis?
Yeah, sure, Annabel. So I was actually away on holidays when I found my lump. I was just putting on moisturizer, and it was in a kind of strange spot. It was quite high on my breast. So I wasn't initially alarmed at first because it was in such a funny spot, but it was still there, a few days later. I thought, it's not the right spot to be a gland. I just thought it was
How big was the lump?
Sorry?
How big was the lump, Karen?
The traditional pea size. So a few days later, it was still there, and I thought, look, I'll be home in 2 weeks. So I actually called ahead and made an appointment with my GP. So I landed back home here in Canberra, and an hour later I was at the GP, and she said to me, look, you're young. It's probably just a fibroid, nothing really to worry about. And I said, look, I'd rather, it's important for me that I'd like to investigate it further. So she gave me the referral for the ultrasound. Again, because it was in a tricky spot, it was hard to get a clear diagnosis of what it was pre-surgery. They could tell it was cancer, couldn't tell what type it was. So by the time I got to the surgeon, she said, look, best case scenario is going to be we remove the tumour, we get good margins, nice and clear, and then you'll probably have some radiation treatment. So it was probably only about 6 weeks between the time that I found the lump and the time that I had the surgery, but it was a really very aggressive tumour. And so by that time, it had already spread to my lymph nodes. So I had the axillary clearance as well. And that's when the surgeon said, look, unfortunately, we're not going with best case scenario treatment now. You're going to have some chemotherapy. And so off I went for the chemotherapy, and that was a pretty tough regime. Again, my oncologist said, look, you're young, you're strong. We're going to throw everything that we can at this. So we went through that and then had the radiation treatment. So, initially I thought having a triple negative cancer was a really good thing. It's like, if you're going to have a cancer, have a triple negative one, and then you don't have to worry about any sort of follow-up medications or treatments. You have your chemo, you have your radiation, and then you're done. And wasn't until later I sort of found some more information. I thought, oh, maybe it's not such a great one to have after all.
And how are you feeling today?
Oh, yeah, really well. I have really good health. So I have, I was really fortunate that even though there weren't great outcomes for people with triple negative cancers at that point, I had a really great treatment team who are able to take great care of me. And I've come, I have side effects like everybody else, touch of arthritis. I've got, lymphedema that I have to manage, and, there's those things, but generally I live just a normal life.
That is awesome and great to hear. Thank you. I'm going to bring in Stephen Luen now because I'm interested. I think that a lot of people joining this discussion, and certainly I don't know much about triple negative breast cancer. Even a couple of things that we've heard from our first two panelists have told me things that I didn't already know. Maybe, Stephen, would you mind starting us off with just a general description of what triple negative breast cancer is and how it differs from other breast cancers? And is it, as Karen initially suggested, a cool form because you can knock it over super quickly?
Yeah, thanks. Thanks, Annabel. Firstly, it's great to be here. It's really an honor to sort of have a chat about this. So I'll go back to kind of the principles that I talk to my patients about, which is essentially whenever someone's diagnosed with breast cancer, one of the first things, one of the most important things we can do is examine it under the microscope. And when we're looking under the microscope, you've already mentioned this, Annabel, there are three main, what we call surface receptors that we are particularly interested in. One of them is the estrogen receptor, the other is the progesterone receptor, and then the third and final one is this protein called HER2. Many of you, of course, will know the terms estrogen and progesterone. So these are hormones. They are normally occurring hormones, and they are particularly important in females, of course. And so we look for the receptors, and if those receptors are absent on the tumor cells, then this is called triple negative breast cancer. There are a few reasons why this is important to us as the clinical team. One is because we know that each of the different subtypes of breast cancer has kind of a different behavior. So we call that the biology of the cancer. So the other subgroups, if everyone's not aware, are the hormone receptor positive, HER2 negative breast cancers. And then the second group is HER2 positive group. The third group is triple negative breast cancer. As you've said, Annabel, triple negative breast cancer makes up about 15% of breast cancers. The other reason why we do it is it helps us understand the risk of recurrence. This is really important because it helps us tailor the treatments. Do you need to give chemotherapy? Do you need to give hormonal therapy? Is that even going to be effective in triple negative breast cancer? It's not. Do we need to consider radiotherapy more aggressively, for example? The third reason is because, all our treatment guidelines are really based on these subtypes. These are what we call clinical subtypes. And so it tells us how to treat it. So going back to the theme of the day, which is triple negative breast cancer, I often will get patients coming in when they see me the first time, and when they hear the news of triple negative breast cancer, it's really frightening for them because often they've done a little bit of reading and they've looked and they've found, triple negative is the bad subtype. I really liked the comment that maybe it would make treatment a bit simpler and so forth, and there is actually some truth to that. And I guess the distinguishing features of triple negative breast cancer are that they do tend to be more aggressive, and by that we mean they grow faster or they replicate faster. There is a propensity for earlier age of onset. So in younger women who are diagnosed with breast cancer, there's a higher rate of these more aggressive breast cancers. If you look back historically, there is a higher rate of recurrence of these breast cancers. So they have previously been harder to control. And when they do spread, they can spread to really difficult locations, particularly for treatment, like the liver, the lungs, and the brain. So these are, this is kind of all the scary stuff of triple negative breast cancer. But there are some positives. One of the positives is because it grows quickly, it is the subtype of breast cancer that really is the most sensitive to chemotherapy. And chemotherapy is a really central paradigm to how we treat triple negative breast cancer, and that's because of these high response rates, and it can make a real difference. The other thing is that we've sort of worked out more recently is that it is the subtype that has the strongest interaction with the patient's immune system. We can tell that when we look at tumor samples because we can see immune cells mixed up with the cancer. And, lots of studies that we've done in the research community have actually shown those to be really important because they can dictate your prognosis. The more immune cells, the better, for example. So I think, that's kind of in the nutshell of a triple negative breast cancer. I think there's a couple of other minor points. I mean, those are general guidelines. There are some caveats. I mean, firstly, no one cancer is the same as another. So there is actually probably some types of triple negative breast cancer that are less aggressive than others. And then there are some that are, for example, more resistant to chemotherapy than others. And finally, there's kind of a new understanding in the research community that, these definitions of these subtypes is not quite so simple. It's a spectrum of hormone receptor expression. So, and the more we look at it, the more we see that those patients with tumors that have very low tumor expression of estrogen receptor are actually very much like triple negative. So that it's kind of an expanding subgroup.
Right. Thank you. That's a very thorough introduction. I think basically this cancer definitely needs some sort of rebranding. I mean, triple negative just doesn't sound good, does it? I mean, anyway, I don't think anyone's going to undertake that. But I have a question from Alison, who wants to know if there's any reason why women are more prone to triple negative breast cancer than other types of breast cancers.
Yeah, that's a great question, and not easy to answer. We've been working on this for a long time. If you look at triple negative breast cancer, about 5, maybe up to 10% have a BRCA mutation, and for triple negative breast cancer, it's most associated with BRCA1. But that tells you that what I mean by that is there is some genetic predisposition that has been inherited that increases your lifetime risk of breast cancer. For BRCA1, it's something like an 80% lifetime risk of breast cancer. And so we know that that's one thing that we've identified why some patients might be more prone to triple negative breast cancer. But the truth be told, beyond that, we don't really know a lot about it. There is a lot of research. So there's a lot of research in the genetic factors, and we can extend BRCA1 and BRCA2. We can go into other genes. So there's a few other genes that are important. We know that, but we don't know much else. And we think there is a whole bunch of patients with, I guess we would call it familial risk. In other words, there is a strong family history of cancer, but we're not able to identify a single gene mutation that's kind of underlies that behavior. So there probably is something there, but we haven't yet identified. It's probably complex from a genetic perspective. Besides that, it's very poorly understood. We don't have any real lifestyle factors that we know are risk factors. Some of you may be aware there feels like there's an epidemic of young people with cancers, and there's a lot of theories about metabolic syndromes, what we're eating, and obesity and so forth. But we haven't got a clear answer for triple negative breast cancer. So there's a lot of work to do there.
Often, every time we do these sessions, we always end up parking a whole lot of stuff in the stuff we don't know yet about breast cancer. But you all make a big dent in, I know, my personal field of unknown things about breast cancer. I'm sure the thousands of people who are on this call. I'm going to quickly play, because we're showing off with the technology, a video question from Glenda. Glenda's asked about survival rates in triple negative breast cancer. Take it away.
Hi, my name's Glenda, and my question to the panel is, what are the survival rates of triple negative breast cancer after 5 years? Thank you.
Okay, so I'm just seeing as we're already talking to you, Steve, and I might get you to pick that up. I know it's a question that zooms immediately into the brain of anybody who sits down and is given the news that they have triple negative breast cancer.
Yeah, so Glenda looked very purple there, which was very impressive. So the good news is the 5-year, if you look at Australian data, which is relevant to us, the 5-year survival rates have been increasing since the 80s, and they're into the 90%. So that's for breast cancer overall. There are nuances, of course, when you look at the different breast cancer subtypes, and historically, triple negative breast cancer has had lower 5-year survival rates. But overall, I think everything's looking really good with modern treatment. the outcomes are improving. And I think the 5-year survival rates are actually excellent in Australia. However, I always have this discussion with patients, that patients will often ask about statistics, but what can be really difficult is trying to understand how that statistic applies to an individual. So when it comes to an individual perspective, though, still the most useful information we get is this thing we call stage. So the cancer stage is a measure, a system we use to understand the extent of the tumor, so the tumor burden, how big the tumor is, whether it's spread to the lymph nodes. I think someone mentioned locally advanced, which usually terms it's either large or involving the lymph nodes, or if indeed it's already spread to a distant location. For patients who have, unfortunately, stage 4 breast cancer or metastatic breast cancer, the 5-year survival rates are very low. That is usually what we consider to be an incurable situation. But anything before that is what we call early breast cancer, and we really aim for a cure in all those cancers. So I think there is good news in terms of the 5-year survival rates.
And I think we always reflect in these sessions that the improvement in the prognosis for breast cancer patients is an extraordinary development over the last couple of decades. I don't want to get too behind, so I'd ask you, Stephen, just to deal with this question as quickly as you can. It comes from Sue, and she wants to know how age affects your diagnosis and outcomes, as she was diagnosed with triple-negative breast cancer this year at 58 years old and is postmenopausal.
Yeah, I'll try to answer this quickly. There is some interesting data looking at age. Generally speaking, younger age is associated with poorer prognosis or higher risk of recurrence. In fact, it's about 40% higher risk of breast cancer mortality, they call it. There was a big study a few years ago that looked into this, but we never really had the granularity of the data to look at the subtypes. And when they looked at triple-negative breast cancer, they actually found there was no statistical difference between the young age and the older age. So, in fact, the outcome from with the right treatment in younger patients and older patients is actually very similar. There are differences in the different other types of breast cancer subtypes, but for triple-negative breast cancer, there's no real main difference between age and also by menopausal status.
Wow, that's so interesting. Thank you, Stephen. Now, we're going to move to our first poll question. As I mentioned earlier, you need to head down to the bottom right-hand corner of your screen to where the 3 dots are and choose polls, because given that we've got nearly 2,000 people here, it's a good sample space to ask about age and being diagnosed with triple-negative breast cancer. Sue, as we've just heard, was 58. There are a lot of younger women that find themselves with this particular variation. So could you take a moment to click on those 3 dots, and if you have been diagnosed with triple-negative breast cancer, could you please choose one answer from the list indicating how old you were when that happened? And I'll come back to you a little bit later with the results. Don't worry, these poll questions are thoroughly anonymized, so you're not telling everybody on the call how old you are. I'm going to move now to Dr. Sunil Lakhani in Queensland. Sunil, many people, we often get recurrent questions in these sessions, and a lot of people have asked about whether there is a genetic link in triple-negative breast cancer and passing a gene down to family members. And if I may be so bold, why?
Yeah, look, indeed. I mean, Stephen has done a great job of explaining some of the background to triple-negative breast cancer, and you already heard about the BRCA1 gene that he talked about. As a pathologist involved in making the diagnosis that patients get, just a couple of things that I would just expand on. So firstly, it's worth emphasizing again that the cancers that arise, triple negative or otherwise, in the setting of familial breast cancer probably only accounts for about 5 to 10% of all breast cancers, which means that the vast majority of triple negative breast cancers that we see are not due to a familial predisposition. So they're arising in what people call sporadic settings, so not in the familial setting. Stephen also expanded on this. For me, it would be a shame if people went away with the idea that triple negative breast cancers were all bad, because as again Stephen explained, they're actually extremely heterogeneous. So while overall it is true that they might behave worse than some other subtypes of breast cancer, there are a whole spectrum of triple negative breast cancers that don't behave that badly. So we shouldn't lump them as if it's a single entity. So that are the two things on which I'll answer the question. So is there a genetic link? Yes, absolutely. Obviously with BRCA1, as you've already heard. And probably about 60 or 70% of breast cancers arising in patients who have mutations in BRCA1 are likely to be triple negative. But again, it's worth emphasizing that not all BRCA1 tumors are triple negative.
It's interesting because, I mean, with all the coverage that people read about the BRCA gene and, Angelina Jolie and all the rest of it, there is an assumption now that you can get tested in advance for your susceptibility to all sorts of variations. Stacey has asked if there are any tests available to see if people are specifically more likely to develop triple negative breast cancer.
Sure. So, I mean, as we said, BRCA1 is an obvious one that you can test for. Over the last decade or so, a number of other genes which are predisposed to familial cancers have been investigated for their association with triple negative breast cancer, and there are a number of them. So, although we don't talk about BRCA2 in the same breath as triple negative breast cancer, actually a small proportion of BRCA2 patients can get triple negative, although most of them are estrogen receptor positive. And a number of other genes like PALB2, which works with BRCA2, a gene called RED51, which is also involved in repairing DNA. So these are some of the genes that have been investigated and shown to be linked to triple negative breast cancer development. And so, yes, from a testing point of view, if depending on where you go, you might have a panel testing done, which includes a number of these genes, to see whether you may have familial predisposition to cancer.
Okay, thank you. Moving on to a question from Marilyn. She wants to know if and when children or adult children should be tested for a BRCA1 gene mutation when there is triple negative breast cancer in the family. Look, this is something that comes up really regularly. So I wonder if you could give us your insights into that question of how early and when it's appropriate to test children and relatives.
Yeah, I mean, by and large, the children will be tested when they're young adults, or essentially 18 years of age, so that they're able to make an independent decision about the choice of having tested or not. Obviously, if you have a triple negative breast cancer and you're being treated in a specialist center, you may be referred, depending on the other circumstances, for genetic counseling and then genetic testing. And if you already know that you've got a mutation in a particular gene, you would still wait until your child was 18 years old before discussing that testing process.
Right. Yeah, it's a tricky scene, isn't it? I wonder if you could just give us a quick, on that note, outline of how you go about getting genetic testing. Yeah.
So, I mean, if you've got a diagnosis of breast cancer already, you're going to be managed by specialists in the hospital, and they will usually refer you to genetic testing, depending on your circumstances, your age, the type of tumor you have, etc. So that's the usual path that that your specialists who are treating you will then refer you to be tested. If you are worried about having a familial disease because of other members in your family, but you yourself haven't got cancer, you can be referred to a family cancer clinic to be assessed. And again, that's another pathway that you can go through to get testing. Of course, if you decide that you just want to do it anyway, even though there's not enough evidence that you may have a predisposition, you can go privately. It's not usually recommended because these things are not straightforward, and depending on where you go, you don't know exactly what genes they'll test. But you may also get information about alterations which may not have any meaning, for you, in which case it creates anxiety without helping you. So essentially, going through the specialist pathway or through the family cancer clinics is a reasonable way, to go and get tested.
How expensive is it to go and get tested if you're taking the private route?
Yeah, that's a good question. Stephen or Jocelyn may have a better answer than me, but I think it'll be in the range of something like $500 to $2,000, depending on where you go to. Is that correct?
Jumping on that, I've just thrown that at Sunil somewhat unfairly without notice, but it's always, in this current cost of living environment, something that is a real strain on people. Anybody got any insights?
Yeah, so genetic testing used to be super expensive, like prohibitively expensive and pretty complicated. I mean, what Sunil said is correct. I think if you can discuss it with your oncologist, that's probably your first bet. I believe for a panel test, it's something around $300 to $500, certainly at our centre. So it is something that some patients might consider, funding themselves to get an answer.
Yeah, and I think the actual cost will depend on where you go. If you go to someone like Melbourne in Peter Mac, that's different to if you go to a private laboratory somewhere. It's likely to be much more expensive.
Great. Thank you, everybody. Well, let's move to the surgical phase of the operation. I'm going to bring in now Dr. Jocelyn Lippey, breast surgeon from St. Vincent's Hospital in Melbourne. Welcome, Jocelyn. I've got a question straight up from Karina, and she wants to know why triple-negative breast cancer remains a challenging tumour to be treated, and what are the treatment options?
Thanks, Annabel. So the reason that triple-negative breast cancers can be trickier to treat than other types of cancers relates to what Stephen was talking about earlier about them not having a targetable therapy. So if you have an estrogen-positive cancer, you've got targeted therapies specific for that estrogen receptor that we know are really effective, and there's lots of different ways that we can block your estrogen receptor, but there's nothing specific for a triple-negative cancer that we can really target. And that's why traditionally it's been quite tricky to treat.
Right, okay. And this phenomenon that we're hearing about it being a very fast-growing cancer, does that, this may be a stupid question, does that make it easier to locate, identify and excise?
It does mean that it's more likely to pop up in between your normal regular screening mammograms. And certainly it's more likely that if that's the case that we find it at a later stage or when the cancer's bigger. Yeah.
Okay, thank you. Brenda has popped up with a question about whether there are any specific symptoms for triple-negative breast cancer compared to other breast cancers. I guess rapid growth of a lump beyond pea size to broad bean size might be one of them, to continue with a sort of pulsar or lupin-based analogy. But are there others?
So I think it's good to answer this question with a bit of a refresher of what the symptoms of breast cancer are more broadly, and then to think about how it might be a bit different for somebody with a triple-negative breast cancer. So the most common thing that someone would notice is a lump. There's other less likely symptoms like a change to the skin, like a dimple, or a change to the shape of the breast, or fluid coming from the nipple. And so those would still be the most common presentations for a triple-negative breast cancer. Like we talked about, it growing rapidly can occur between the intervals which you have in your normal mammograms. And so it's really important, if you notice any of those symptoms in between your normal mammograms, that you go and see a doctor rather than think, I've just had a mammogram, I'm sure everything's fine. But the only way that I've seen triple-negative breast cancers present slightly differently is they're the only breast cancers I've known that have caused pain, and even then it's very rare. So it's a very, it's quite unusual even in that patients with triple-negative breast cancers have pain, but they're the only painful lumps.
And earlier when we were first hearing about Diane's symptoms, she was talking about the lump being in a sort of an unusual kind of place and thinking, well, that's not really near any glands or nodes. Is that a regular feature?
That doesn't happen often, but certainly can happen. It's important to know that your breasts actually extend all the way out to your armpits. So you have breast tissue that goes all the way to your armpits as well. And so that is considered part of your breast as well.
Right, okay. Now, Eliza has asked about neoadjuvant treatment, and I'm frankly relieved because I have no idea what neoadjuvant treatment is, and I'm hoping that you will be able to enlighten me and everybody else on this call who is similarly handicapped in this area. How does this provide information about how effective treatment has been before surgery?
The neoadjuvant just means that we give it before surgery. So adjuvant means extra or additional. So traditionally, surgery would usually be the first port of call for any treatment for breast cancer. And then the adjuvant treatments would be chemotherapy, radiotherapy, hormone blocking tablets. And neoadjuvant is where we give the chemotherapy before the surgery. And this.
Why would you do that?
I beg your pardon?
Oh, sorry. And what are the reasons for doing that?
So this is something that we've been doing more and more, especially for triple-negative breast cancers. And then there's another subtype of breast cancers, the HER2 positive, that we do a lot of chemotherapy before as well. And that's to give us information about response. So we know exactly how somebody's tumour has responded, and it allows us to know firstly, do we need to be changing what systemic treatment that they're having through their chemotherapy, but also, did the chemotherapy completely rid the breast of the cancer, and therefore do they need any extra treatments or not afterwards? So it can really help us to personalise treatment and does improve prognosis.
Okay, so Shireen has a question which is kind of the flip side of that previous one from Eliza. She's asked, how do you know if chemo is effective if treatment was received after a double mastectomy?
Yeah. So you don't get that same direct information that you get if you have your chemotherapy before, and then we can tell you exactly how effective that has been. The simple answer to that is actually we can't give you that personalised information of how effective your chemotherapy has been for you, but we know that when we look at big groups of women in trials who've had chemotherapy after their surgery, that there is a survival benefit in receiving their chemotherapy, but it is hard to exactly quantify that for one individual.
Jocelyn, do you find that there is, and this is just a question I'm throwing in, my apologies, do you find that there is a tendency among women that you see to want surgery because they want this cancer out of their body? I mean, I've talked to a number of people who feel very strongly that way.
Yeah, certainly that's something that I've come across, and it makes complete sense once you've found out there's something in your body that's not right or causing you harm, that you certainly would want that out as soon as possible. And that's when we would explain the benefit of giving chemotherapy first and the advantages that that has for that woman or patient. And normally after you've explained that, people sort of say, okay, all right, I understand that we're better to go with this approach.
That's a journey of understanding, isn't it?
Yeah.
It's a really steep learning curve, learning-wise. So we have another video question now, and it's from Karen, who wants to know about traditional versus alternative versus traditional therapies.
Hi, my name's Karen Gordon, and my question for the panel relates to traditional versus conventional therapies and treatments. In particular, I'm curious of the success of medicinal cannabinoids, not only pain assistive, but actually attacking the triple negative cancer. Thank you.
Thank you, Karen. Treatment of breast cancer, and especially treatment of triple negative breast cancer, is a multidisciplinary effort. It involves the input of lots of different specialists, so surgeons, medical oncologists, radiation oncologists, pathologists, everybody. And a little bit of the problem of the alternative therapies is that they function almost in a bit of a different realm. So when you're having treatment, your treatment team will be closely communicating about what you need. And there's a bit of a concern about the impact that extra alternative therapies could potentially be having on the treatment that you have. There's a really wonderful resource put out by Memorial Sloan Kettering, which is a cancer centre in New York, have a website of all the different herbs, and they have all the data and evidence about what we know about different alternative therapies, and that's really helpful to get patients to negotiate that. I think the most important thing about alternative therapies is that you're open with your treating team about what you're taking, because it can potentially impact on what treatments you're having. Some additional, alternative treatments can make you bleed for surgery, so certainly something I'm very interested in, and obviously can impact on your metabolism for different chemotherapy. In terms of cannabinoids, the evidence that I've seen is that actually it's not a particularly effective analgesic when we looked at it in randomized controlled trials.
So I guess the main takeout there is make sure that you have a really open conversation with your oncologist about what's happening and what you're thinking about, what you're taking. And I guess different doctors will have a different degree of patience with or interest in alternative therapies. Okay. Listen, I can bring you the, thank you for that, Jocelyn. We do have results through from our Schmicko poll, and it's revealed that viewers in the age group of 50 to 60 were the most common. They topped the poll of when they were diagnosed with triple negative breast cancer, followed by people aged 50 to 60 years. So thank you very much for your participation in that poll, and there'll be another one coming up. Stephen, I'm going to jump back to you. One, to just quickly ask you about the results of that poll. Does that sound about right to you in terms of, this is obviously not a scientific sample. We would have to control for propensity to dial into a Zoom at 4:30 p.m. and so on. But I mean, does that sound right-ish to you?
Actually, it sounds really quite right. So as we said before, there is a younger age, they tend to get the aggressive cancers, but they're still pretty uncommon. So in fact, we see much more triple negative breast cancer in those age groups, 40 to 60. We still see them in older patients as well, but the vast majority of older patients tend to have hormone receptor positive HER2 negative breast cancer. So I think it's fairly reflective, actually.
Okay, well, look, let's move on to another really hot topic of interest across the group. And this question comes from Deirdre. And she wants to ask what the likelihood is of breast cancer recurring after you've had triple negative breast cancer.
Yeah, thanks. That's a good question. I was quite struck by Diane and Karen's stories because, I mean, in essence, they had very similar cancers, but they were treated so differently. Diane had really the modern treatment, which is what most of our patients are receiving now. And Jocelyn mentioned the neoadjuvant approach. And in fact, the vast majority of patients with early stage triple negative breast cancer will get or will be offered or recommended neoadjuvant treatment, usually with immunotherapy and chemotherapy, followed by surgery. And so part of the reason we do that is because it gives us more information about the likelihood of recurrence. So in fact, there was, the treatment that we use in the neoadjuvant setting is based on a trial called Keynote 522. And in fact, there's just been an update in the last week at the European Society of Medical Oncology with the 5-year survival estimate. So that gives us a real sense of what the recurrence rates were in that population. So we know that when we give, as I said before, cancer stage is really important, but the other bit of information that tells us about your recurrence risk is the burden of tumor when we get to surgery. So that's after the chemo and the immunotherapy. We know that about 65% of patients get what we call a complete pathological response, which means when we do the surgery, we cannot identify any viable tumor cells, which is amazing. We know that those patients do extraordinarily well. In fact, at 5 years, they call it the event-free survival, but the risk of recurrence is very low. So the survival rate is 92.2% at 5 years, so very low rate of recurrence. However, in the patients who still have residual disease at surgery, there is a much higher risk of recurrence, so about 38% risk of recurrence. So this is exactly what Jocelyn was mentioning, is that we can kind of start to personalize the idea of risk of recurrence, but also use that information to try to understand, do we need to give a different therapy? Do we need to give more chemotherapy, for example, in the adjuvant setting after surgery, to try to target those patients most at risk? So we're using that data to help us understand a patient's risk.
And as we all know, a statistic is just a statistic until you fall on one side or the other, right? It's essentially meaningless. Marie, though, has asked if there's any research or findings about the likelihood of recurrence diminishing the longer you get from your initial diagnosis. Is it a curve?
It's definitely a curve, and the curves are very different for the different breast cancer subtypes. So breast cancer is quite well known to be able to recur quite late. And in the research community, we use this arbitrary definition of 5 years. So 5 years after surgery is considered a late recurrence. However, triple negative breast cancer, the rate of recurrence after 5 years in that late period is actually very low compared to the other breast cancer subtypes. So, there is a diminishing risk. So if you get to 5 years and there hasn't been a breast cancer recurrence, it is becoming vanishingly small, the risk of recurrence. And we know that, we've known that for a long time. And even going back to that Keynote 522 study I showed, even, you know, the difference at 3 years versus 5 years was very small. So already those curves plateau or start to plateau at around 3 years. Now, that doesn't mean the risk of recurrence is zero, but it does make a difference. And I think, you know, patients do find that useful information.
Great. Okay, that is super useful. And I'm just going to play a quick video question from Robin, which is also about recurrence. Robin?
Hi, my name's Robin, and my question to the panel is, what are the most effective ways of minimising recurrence of triple-negative breast cancer?
Go on, Stephen. You may as well take this. You're on a roll.
Yeah, it's quite a broad question. So obviously, if I take you back all the way, you know, we initially, you know, a long time ago, just did surgery, and it became clear that surgery alone is often not enough for triple-negative breast cancer. This is a cancer that loves to spread to distant sites. So we started thinking about chemotherapy, because chemotherapy is a systemic agent and can try to, I guess we say, to try to eliminate what we call micrometastatic disease, so reduce that risk of distant recurrence. And so I feel, you know, the treatments we recommend are an important part of reducing recurrence. When you've finished your treatments, there are a number of things that we will often talk about with patients that have, you know, reasonably good data for minimizing your risk of recurrence. And I think there are some questions later on about this, and often those are lifestyle factors, things like regular exercise. You know, there's quite strong evidence for exercise. There is some data for weight loss. Weight loss, I know, is extremely difficult to achieve, particularly because of hormone changes, and often when we give chemo, that can affect, you know, your ovarian reserve and your menstruation, and that can affect the ability to lose weight. From a diet perspective, there's some good data on sort of, you know, healthy eating, lower fat sort of diets, and also minimizing alcohol and not smoking. These are all really important factors. We've mentioned genetic factors. Often these patients get tested. That's a whole different group that has different risks and have different approaches. But those are the really important things. It basically comes down to living as healthily as possible.
It's very depressing, Stephen. Every time this question comes up in these sessions, the answer is always, you know, no more wine and cheese and go for a run. But, you know, one day the news will improve. Sunil, I'm going to just switch to you. While we're asking simple sounding questions that have giant and complicated answers, Maxine wants to know, what causes breast cancer to come back elsewhere in the body?
Yeah, so that's a sort of $1 million question, really. You know, in biology and medicine, talking about causes is always.
Were you muting or just glitching?
No, excuse me. Sorry, that's me. My phone started ringing.
Oh, good.
I apologize for that. So as I said, it's $1 million question. The issue with causes is always difficult. When a cancer starts to grow at its primary site, let's say in the breast, some of the cells will have the ability to break into blood vessels or lymphatics, which is why they go to lymph glands and travel around the body. Some of the cells also have the ability to resist treatments that we give them, you know, because they've developed those mechanisms. The whole process of metastases was actually kind of the hypothesis around how this happens was delineated maybe 200-300 years ago, when a surgeon in the UK called Stephen Paget talked about the seed and soil theory. So the idea is, you know, if you went into your back garden with a whole bunch of seeds in your hands and threw them into the grass, will they all grow? And the answer is no. Some of them will die in the process of being, you know, getting to the soil. Others will land in the organs around the body, the tumor cells, and some of them will grow there. Others will just sit there and do nothing for long periods of time and hibernate for a while, because they need to adapt to that new environment in which they find themselves. So we don't really understand all of the mechanisms, but there's quite a lot of research going on in trying to understand how those cells escape and how they land into the different organs, and what are the factors that allow those cells to eventually grow out in those sites. So causes is difficult because we don't know exactly what causes it, but there are inherent properties within the cancer cells, as well as the way it interacts with the sites at which it grows.
Okay, thank you. You've elegantly canvassed the vast boundaries of this question. This one might be a bit more answerable, I think. Anne has asked whether a recurrence of breast cancer is likely to be triple negative if the original cancer was triple negative.
It's likely, but it's not invariable. Cancer cells are very adaptable, and they adapt to their changing environments all the time. So if a estrogen receptor positive cell went to other parts of the body, it may retain its estrogen positivity, or in some parts of the body, it will change to become negative. So triple negative cancers can become estrogen receptor positive and vice versa. And probably about 10-15% of tumors will change their phenotype in this way, which is why, if you do get a metastasis that you can take a biopsy of, it's usually a good idea, because you want to see what the phenotype is in the place where it's now growing, rather than relying on the original diagnosis for making a treatment choice.
Okay, thank you very much, Sunil. That was beautifully answered. Well, because one thing, I guess, to talk about the statistics and the incidence of recurrence and treatment and so on, but it's another thing to live under the constant threat of it. And so I want to just go back to Diane and Karen and ask them a little bit about the reality of life in those circumstances. Karen, your breast cancer was about 12 years ago now, and thinking about Stephen's curve, I guess, gives you some comfort. But does the fear of breast cancer recurrence ever really go away? And how do you manage it?
I've been very fortunate, had great outcomes from my treatment. So I don't think that I really have a fear of recurrence. And I think, throughout the treatment, and, my partner was great and really supportive, and always really helped me to be forward-looking and positive, even when he was making me beetroot and kale smoothies, which were just horrendous. But we'll give it a go. But so for me, I guess it's more, every now and then something will happen. I might see something, or I might hear something. As we mentioned, I'm part of the consumer advisory panel, so I get to see a lot of the great information and stuff that comes out of the trials. But it really reminds me how fortunate I am to still be alive, because again, 12 years ago, the outcomes weren't as good as they are now. So it's almost like, for me, it's bonus time. So I have a really great opportunity to still be positive and look forward. So I don't really have that fear of recurrence.
And I guess fear often is about the vast sort of dark universe of stuff that you don't know about breast cancer, right? Which is where a lot of people are when they get that diagnosis. So I think one thing that I've learned from these sessions is that it seems to get, the more control you have through knowledge, the more the fear lessens, I guess, over that journey of discovery. So if anyone is listening to this session at the very beginning of that journey, I think it's worth listening to our veterans on this panel about to what extent finding out what's going on can assuage that anxiety. Diane, obviously your diagnosis was much more recent in 2020. Are you suffering scanxiety? Does breast cancer recurrence, is it something that monopolizes your attention and your mind, and how do you manage those thoughts?
Yeah. Thanks, Annabel. First of all, it's so delightful to hear Karen's survival story. It's amazing. It gives a lot of hope to women who have been diagnosed with triple negative breast cancer. Like Karen, my cancer was incredibly aggressive. I think it had a 90% reproduction rate. So it was galloping away from me.
What does that mean? Sorry, Diane. What does a 90% reproduction rate mean?
I might not steal the thunder of Stephen. He'll probably explain it much better than I would. But my understanding is that the rate at which the cells reproduce was, almost, crazily, incredibly swift. So it was at that very upper end of how the cells divide and reproduce. Stephen will explain that in a more scientific and eloquent fashion. But
no, I think you've done a great job.
Pretty good job.
So I think I think they do a test, and Sunil might be able to say more about this, but they do a test called a Key 67, which essentially tells us what proportion of the cells at that snapshot in time look like they're about to make a copy of themselves. Right. So the higher proportion, the more aggressive, the more rapidly we think it'll grow. Okay,
well, it sounds like you did a pretty good job there, Diane. Just, have you got any tips for how you manage that sense of anxiety?
Yeah, and it's very real. So I'm still within that sort of risky phase. I'm coming up to 3 years post-diagnosis, and you know, there were points in time when I didn't know whether I would still be here. You go through that fear pretty regularly, I think, at least in the early years. In fact, I had a scare just a few weeks ago. I had my surgeon was a bit perplexed. I had what looked to be a very delayed post-radiotherapy skin reaction, which triggered some urgent ultrasound testing, which then showed something that was unusual. It was fine. It ended up just being fat necrosis from my reconstruction, but it catapulted me straight back to that initial phase. I had to get a biopsy and had to see my surgeon and the specialist breast radiologist, and it was very triggering, actually. So yes, it's always there. It's always in the back of my mind. And the other thing I think for me, and Stephen alluded to this, is that my residual cancer burden score from the pathology after my surgery was the poorest result that was possible. So that was terrifying to get that. I'd been through all of the chemotherapy. I was halfway through immunotherapy. I'd had surgery. Then I got that result, and it was grim. My oncologist gave me some reassurance. I've been pretty well since then, so I take that on board. But the way I deal with it is, I religiously stick to my follow-up appointments. I'm never late with any of my scans now, of course. If anything unusual happens, like what happened a couple of weeks ago, I'm straight onto it. I speak to my specialists. I'm very vigilant about my health. And I also take my exercise, my diet, all of those sorts of things really seriously. I was told right at the very beginning, I think in my first appointment with my medical oncologist, that exercise is part of my prescription. I have to exercise. So I got a referral to a specialist cancer gym, and I continue strength-based exercises, cardiovascular exercise, all sorts of things. Meditation is really great. Counselling. There's a really great organisation called Headway Health, which has a specific program dealing with the fear of cancer recurrence. So I can highly...
What's the name of that organisation? Could you just say that again a bit slowly?
Headway Health. They're really fantastic. They are a group of specialist cancer psychologists, and they have developed a program that helps cancer patients in particular deal with the fear of cancer recurrence. So they've got a whole program they've developed, and that's been really good. But for me, coming up to 3 years, knock on wood, I'm feeling well, and I do now feel like I've been given a second chance, and I'm really taking that seriously as well. So trying to stay positive helps. You have low points, but I am very grateful for where I am at the moment, because I wasn't always assured that I would be in this position. So that's good. Take it one day at a time.
Hey, Diane and Karen, I just want to thank you again for your openness and preparedness to chat about this stuff. It's not easy to revisit, I imagine, but I think anything that you can do to relieve that sense of fear and ignorance among other people that might be on this call is a really generous thing to do. So thank you very much for being so prepared to help. We're going to go to another poll question now. So hover over your triple dots and select poll, because we're going to ask this question. Where are you on your breast cancer journey? Are you currently going through treatment? Are you 0 to 5 years post-treatment, 5 to 10 years post-treatment, or 10 years and over post-treatment? So again, click on those 3 dots in the bottom right-hand corner, choose polls, and then just choose one answer for that second poll question, and I'll bring you those results shortly, actually quite shortly, because as always happens, we are scooting towards the end time of this session. I think we could probably go for hours with the questions that we have, but people have got lives to live, dinners to cook, and all that sort of thing. I am going to go now to Jocelyn and bring you a question from Joe, who's asked, what is the role of exercise in contributing to the management of triple-negative breast cancer? Now, I know we've heard quite a bit about exercise from the rest of the panel, but I'd be really interested in your perspective on that, and particularly with relation to triple-negative breast cancer.
Thanks, Annabel. So we have heard about Stephen's answer to Robin's question, which is about the importance of the effectiveness of exercise to reduce the risk of breast cancer coming back. In terms of triple-negative breast cancer specifically, it can help manage the side effects of chemotherapy as well. that can be a really important part to play, as well as decreasing the chance of the cancer coming back. It sounds like Diane was involved in an exercise physiology program, and so this is a subspecialty group of physiotherapists that works specifically with people who need specific exercise requirements, and they can really help people get into a regular exercise routine, as well as something that's specific for them depending on what type of surgery they have. They might have limitations about what their shoulder can or can't do, so it's helpful to get a professional advice for that.
I was today years old when I discovered that there were specialist cancer gyms, actually. Are they very widespread, accessible? Do you know anything about them? Because I don't.
There are a couple that I know of here in Melbourne. Certainly the bigger private hospitals that do a lot of breast cancer work have exercise programs integrated into their hospitals as well. I'd ask your oncologist and they should be able to help you.
Yeah, okay. Amazing. Okay. Also, is there an extent to which, even if there isn't a clinical assistance of, contribution to the management of breast cancer, it's generally the truth that reasonable diet and exercise is a contributor to good mental health, which in turn allows you to deal with everything that life's chucking at you a little bit better as well, right?
Absolutely, yeah. Yep.
There's a question here on something a bit different from Sandra, who wants to know whether high doses of vitamin C, like infusions, actually assist in the treatment of triple-negative breast cancer.
So in vivo experiments have shown that high doses of vitamin C can kill cancer cells, which is where the origins of this have come from. But I would consider it to be an investigatory drug. I wouldn't say that it's mainstream, and certainly it shouldn't be used outside of a clinical setting. It does have the potential risks of interacting with the metabolism, some really common drugs such as Panadol or even chemotherapy, and so it's really important if you're considering taking high doses of vitamin C or an infusion of vitamin C that you talk with your treating team so that they're aware that that's going on as well.
And as remarked earlier, always be open with your oncologist and doctors about what it is that you're dabbling in. Okay, I've got some results through from our second poll. Right, so it seems that in this group currently on the call, 45% of viewers are currently going through breast cancer treatment, followed by 38% of viewers who are 0 to 5 years post-treatment. So we've got a lot of people in Diane's situation, a lot of people in pre-Diane's situation. And Karen, thank you very much for being here and giving us giving this large proportion of people a little bit of a glimpse of what it's like further down the tunnel where it's a bit lighter. I'm going to change the topic now and talk about research into triple-negative breast cancer. And it's time for us to have a quick look at something that Breast Cancer Trials has been working on and done a number of studies into, including the NEON clinical trial. Let's just update ourselves with a little bit of an information video about NEON.
The NEON trial is a neoadjuvant trial. That's where we give the treatment prior to surgical removal of the breast cancer. In this study, we're looking at triple-negative breast cancer, which is around 15% of all breast cancers, but has the chance to be the most aggressive. So the aim of the NEON trial is to try and shorten the chemotherapy and incorporate immunotherapy in the treatment of this disease. Triple-negative breast cancer has traditionally been treated with chemotherapies, which has the side effects. So what we're trying to do now with the new therapies is to try and give less toxic chemotherapy and hopefully still have the chance of producing more cures than what we did before. Immunotherapy has been on the radar now for a number of different cancer types. In breast cancer, it's only just starting. The idea is that because your immune system is flexible and has memory, the patient with the breast cancer who receives immunotherapy can develop an immunity to their breast cancer, so they never see it again, essentially. We've had a number of groundbreaking immunotherapy trials, and this trial will introduce a new type of immunotherapy as well as a different chemotherapy regimen for triple-negative breast cancer.
Okay, Stephen, I'm going to go to you because the results of this NEON clinical trial are expected quite soon. What can you tell us about this research from your perspective and what the potential is for immunotherapy to assist in the treatment of triple-negative breast cancer?
Yeah, thanks. I should disclose that NEON is what we call an investigator-initiated trial, and I was involved in its development. I worked very closely with Professor Shireen Loy, and if you look closely, you can see my back in that video in the lab. I mentioned before, triple-negative breast cancer is the subtype that has the strongest relationship with the immune system. We have developed ways of looking at that very simply under the microscope by just looking at immune cells. And we worked out when these new drugs were coming through, they work spectacularly in some tumor types. So you've probably heard of some of the success in melanoma, a lot of that work driven through Australian investigators as well. But in breast cancer, we have had to work a lot harder to make the immunotherapy work. So the way we've sort of worked out is to try to optimize its effect. We need to use it with chemotherapy in some ways, but also to bring it in earlier. So this is why we brought it in the neoadjuvant phase, because if you use that sort of window of opportunity to really increase your chance of cure, then the magnitude of effect you can get is much higher. So, immunotherapy has now become available because of really important clinical trials, but NEON asks a little bit more of that question and asks, how do we best use immunotherapy? There are two parts to that in NEON. One is, can we get rid of this drug we call the anthracycline? Many of you will know from that poll what the anthracycline is. That's the doxorubicin, that's the red devil. Most of you will know what that is. In a lot of trials we've kind of found that maybe we don't need that drug. So this question is, can we sort of reduce the chemotherapy because of the additive effect of immunotherapy? Do we need that doxorubicin chemo? The second question we asked in NEON is, if we give the immunotherapy first, can it prime the tumor so that it is more visible to the immune system, and so you get a greater effect? So I think there's some really interesting questions being asked by NEON, and we will get some answers to that. And we're going to we're really going to try to understand how to optimize immunotherapy use in triple-negative breast cancer.
Stephen, is the potential for this research, does it differ depending on whether you have early stage breast cancer or metastatic breast cancer?
Yeah, so for immunotherapy, it's a really interesting story. So I'll try to be very brief, but when we develop drugs, when we try to understand how they work, usually they start off in the very advanced setting. So patients with metastatic disease, usually once they've exhausted all their standard options. And we found that the treatments, when you just use immunotherapy by itself, they can work, but the chance of response is pretty low. And there's a couple of reasons for that. One is because the immune system, the relationship with the immune system tends to decline with advancing disease, but also because the cancers become kind of more resistant over time. So using that knowledge, we then started to bring it forward. And there's this really interesting scenario where when we use it in the advanced setting, the immunotherapy, it seems to only be useful when patients have this marker on their tumor called PD-L1 when it's positive. Whereas in the early breast cancer setting, it seems to work in both the positive and negative group. So there is a real difference in the biology between that early stage and the metastatic stage. So try to understand how to implement those is quite a different kind of thing.
Wow, that's so interesting. Sunil, I might bring you in now because we have a video question from Karina, which is about research.
Hi, my name is Karina and my mother is a survivor of triple-negative breast cancer and one of 6 women in 2 generations of our extended family to have it. I would like to ask the panel what research is currently being done into genetic testing for risk factors for breast cancer beyond BRCA1 and 2.
Yeah, so as we've already talked before, besides BRCA1 and 2, there are a number of other genes that can predispose to triple-negative breast cancer, which are part of the panel testing that takes place. So certainly that's been happening, and we know a little bit about that. In terms of the other genes, as I again mentioned before, the vast majority of triple-negative breast cancers are not going to occur in the familial setting. And for that, there are very large consortia around the world looking at whether there are genes that that are very common within the population, but give a small increased risk of getting breast cancer in the general population. So they're not the very strong genes like predisposition genes like BRCA1, 2, which are very highly aggressive. There are genes which have a low risk, but there are many genes like that which are in the population. And these studies called genome-wide association studies are looking for those risk genes in the population. And one of the things that kind of comes out of that is the ability to then combine multiple different genes to see whether cumulatively they provide enough risk that becomes interesting in terms of managing patients. So these things are called polygenic risk scores. So you try and get multiple genes with low risk individually, but combined may give enough risk that you can use to identify patients who might therefore be at risk of getting breast cancer. So that's where the genetic research is going on in terms of non-familial breast cancer.
Great, thank you. Sunil, it's one thing, I guess, to talk about this sort of furious activity on research into treatment of triple-negative breast cancer, but a few people have asked about how the state of research into the treatment of the side effects of the treatment for triple-negative breast cancer. What kind of side effects are the most common in this form of cancer? And is there research that particularly targets those signature issues?
Well, I mean, you've heard that, by and large, most of the patients will get chemotherapy, immunotherapy, and so on. And the side effects are obviously well known to patients, everything from nausea and vomiting to hair loss, getting various types of inflammations that damage tissue like the heart or the lungs, etc. And people get anemia, so you get blood, disorders because of the chemotherapy. When pharma are developing those drugs, they're obviously looking for the toxicities because otherwise, they're not going to get it onto the market if they're very toxic. But if the drugs are possible to bring into clinical trials, then the clinical trials research will also be looking at whether there's an association between, for instance, dosing of those drugs and what kind of toxicity you get. And Stephen just mentioned something that people call sequencing, which is which order do you give the drugs in? And does that also make a difference to the toxicities? Because essentially what you're trying to do is to get the maximum benefit with minimal side effects. And that process is an iterative process often where you're trying to develop those drugs and the sequence in which you give those drugs to maximize benefit and minimize those impacts. In terms of the future, since we've been talking quite a lot about genomics, one of the things that's emerging, which is not a standard of care at the moment, but is emerging, is doing blood tests on people to look for their underlying DNA and looking for genes that might be present or absent or mutated, which are involved in metabolism of drugs. So there's a whole new area of genomics that's coming through called pharmacogenomics. And here we're looking for alterations that might tell you upfront whether the patient is likely to react badly to certain drug types or actually be more sensitive to certain drugs, in which case you can use them. So I think in the coming years, we'll see more of those kind of pharmacogenomic data coming through, which will personalize the way we treat patients and reduce their risks.
I'm going to come back to you, Stephen, in a second, just about the broad spectrum of where research is at on triple-negative breast cancer. But Louise has asked in the meantime, Sunil, a pretty practical question. How do you find out about clinical trial research with a view to participation?
Well, I mean, if you're having treatment with your specialists, in hospital, the first thing to do is to ask them, as they're considering your treatments, whether there are clinical trials that you can participate in. And of course, breast cancer trials, we've just heard about the trial that you saw in the video. You can go into the website for breast cancer trials and see what clinical trials breast cancer trials is involved in. And if you need some more information, you can always call up our staff and they will help you. So those are the two main avenues. Speak to your treating doctors. They should know what trials are going on in the hospitals.
Great. Okay. Stephen, we're sort of starting to wrap up now, and a lot of people asked in the questions, look, where is research up to for triple negative breast cancer? It's a pretty broad question, but can you provide any insight into the direction of this research?
Yeah, extremely broad question, but I'll try to give some sort of brushstrokes. So firstly, breast cancer is, we ask a lot of patients when we give treatment. And so there's a new concept in breast cancer about understanding which patients can de-escalate. So at the moment, for triple negative breast cancer, it's probably the last subtype where we've de-escalated because, it's the aggressive type of cancer, and we've often gone, the full kitchen sink. So we're sort of trying to understand, who can have less treatment, who needs the treatment, et cetera. I think personalized biomarkers is a really important part of that. The other thing that I do particularly, that I have a particular interest in, is drug development. So I often do early phase trials, even first in human trials. And I think it's a super exciting time to be doing trials because there's a lot of new technology and advances in medicinal chemistry coming through. So there are, one of the biggest moving fields is a group of drugs called antibody drug conjugates. So we've talked about how triple negative breast cancer doesn't have a target, but that's, becoming completely untrue really, because these antibody drug conjugates are actually targeting real targets on the tumor like TROP2, B7H3, B7H4. We're getting new PARP inhibitors that are more selective and potent. It's going to be more around understanding how these fit in. At the meeting, the European meeting, even this last week, there's been lots of really exciting changes. And I think there's plenty to come from a research perspective.
Oh, great. Thank you. That was an awesome overview. I'm just going to conclude our questions by going back to Diane and Karen. And I will also, Jocelyn, if you want to jump in and talk about anything that is going on in your field that particularly surprises and excites you at the moment. Do you want to jump in now if you've got something to point out? I'm just conscious that you represent a different part of the process. And
yeah, I do. And it's interesting because Stephen's right, a lot of breast cancer trials have been moving towards personalising treatment for patients. So when can we safely do less? But really, and that's a very surgical question as well. When can we be doing less surgery? But often, for triple negative cancers, we're quite wary of that. Yeah.
Okay. All right. Thank you. Look, I'm going to go back to Diane and Karen now because, you've lived all of this, and I wonder, let's go in chronological order, I guess, and ask Karen first. What your hopes are for the future in the treatment of triple negative breast cancer.
I think that the treatments the way that we're moving now is incredible. The treatment that Diane has described that she's having, the immunotherapy, those kind of things where we can try and target the cancer early in a different way so that you don't have to have such aggressive treatment in the end. Stephen talks about the red devil, and I remember the red devil well.
I don't know what the red devil is. I'm sure lots of people on this call do, but some mightn't. And what was it like?
Oh, look, I think another thing that Stephen mentioned, I called it kitchen sink chemo. It's like where you do really get everything thrown at you. And I remember talking to my oncologist asking her what my treatments were post, and she said, "Oh, that's right, I gave you the red devil because you were young and strong." It was just a really tough chemo regime. So it was just one of the 3 chemo drugs that I had as part of my treatment, and obviously that was the one that made me feel a bit more poorly than the others. But yeah, so I think that it is that de-escalation. It's trying new things that are really moving in the right way. And what Diane's described, while it was difficult and, she's obviously needed a lot of personal strength to navigate it, it's moving in the right direction. And, I think that's great. And as we continue along that path, it'll just be, it's just better.
Okay. Thank you, Karen. And Diane, Karen, who's a decade ahead of you on this journey, says she thinks that things are moving in the right direction. What direction would you like to see things move in over the next 10 years?
Thanks, Annabel. I think if we can move away from the Red Devil, that would be terrific, because it really was quite shocking. It's an awful treatment, necessary but awful. Obviously, I would love to get to a point where we can say that we have a viable cure for triple-negative breast cancer. I think that's the ultimate aim for any form of cancer, really. It takes more research, a great deal of funding to fund the research, willing clinicians to engage in this sort of research, therapeutic drugs. I'm very encouraged to hear what Stephen's been doing in his field. Participation in clinical trials as well, if I could just mention that. I was lucky enough to have a medical oncologist who was very active in the clinical trial space, and that was the reason I was referred to him in the first place, because it was thought that I might be able to be involved in that. And I was, post my treatment, actually involved in a clinical trial where the first phase of it was having a circulating tumour DNA blood test every 3 months. And it felt for me like an additional safety blanket, because normally when you finish your treatment, you then go into that sort of maintenance phase where you have your 6-monthly checkups or whatever they are. I was getting these blood tests where at a molecular level, my clinicians were able to say there is no trace of cancer in your body at all. And I can't tell you what a difference that made to my mental state, knowing that there was nothing there, nothing to see here. So getting to a point where having something like a circulating tumour DNA blood test as part of the standard post-treatment protocol would be amazing, I think, for cancer patients and those who have recovered from cancer. But the other thing I'd like to see is equity in terms of access to drugs. Cancer is expensive, and we haven't talked about that, but cancer is an incredibly expensive disease to have. I worked full-time throughout my cancer treatment. I don't know that that was the right thing for me to do, but I didn't have to work. I could have taken time off. But I know that a lot of cancer patients do have to work because it is expensive to access the treatment. The immunotherapy drug protocol that I was on, I paid for that. And yes, it was prohibitively expensive, but I did it because I was in a very risky phase of my cancer development. So I made that decision, and I think it did make a difference. But having equitable access to treatment, remote regional patients, Indigenous patients, it's all really important that we look at this from an equity and access issue as well. So I'd like to see some more focus on that too.
Thanks so much for raising that, Diane, because it's sort of like a double spiral of uncertainty, isn't it? You don't know whether this treatment's going to work for you, but you also don't know if you're going to be able to afford it, if you're going to be able to get on a trial. It just adds really significantly to that burden of uncertainty, which also translates into fear and apprehension. I also want to say that, I think part of participation in a trial is to have some security for yourself, but also to know that you're contributing to a field of enterprise that might make things easier for people that come after you. And I think I particularly want to thank anyone on this call who's been involved in especially stage 1 trials where you're not really sure what's going to happen, but it's all part of this extraordinary process of advance that we've been hearing about this afternoon. We are out of time, and I'd like to thank Diane and Karen for being so generous with their insights and their experience of a very personal and difficult time. And of course, I'd like to thank Sunil, Jocelyn and Stephen, who are horrendously busy individuals who have taken some time out, a good chunk of time really, to engage with 2,000 people who are looking for more information. Thank you for providing it, and thank you for providing it in such an articulate and clear way. I'll remind you that this Q&A has been recorded and it'll be available on the Breast Cancer Trials website tomorrow. So anyone who's on this call will receive a link so that you can watch back or share with anybody that you can think of that might be interested in anything that's come up this afternoon. You know that Breast Cancer Trials is committed to improving outcomes for every person diagnosed with breast cancer through clinical trials research. They also rely on community support to help in this cause. And so if you or your family or friends would like to make a donation, you can do that again via the website at www.breastcancertrials.org.au. Well, we've come to the end of another session. As ever, I walk away from it a little bit smarter than I was when I walked into it. Thank you all for sharing, and thank you to everybody who dialed in for sticking with us and for sharing in this feast of information and intelligence. Thank you. We'll see you next time.